Pancreatitis. As early as 1961, Charles et al. Described a form of idiopathic chronic pancreatitis with obstructive jaundice and hypergammaglobulinemia. Later on, in 1995, Yoshida suggested autoimmune nature for this variant of acute pancreatitis. Then in 2001, Hamano noticed a close association between this variant and the high serum IGG4 level. Then in 2002, they noticed that not only IGG4 in serum, but also plasma cell infiltration in the affected tissue are positive for IgG4. Later on, multi-system affection, other organ involvement was recognized by the end of the first decade of the 20th century. That's why in 2011, International IgG4-related disease symposium held in Boston suggested the term IgG4-related disease as a multi-system disease rather than autoimmune pancreatitis. So, by definition, IgG4-related disease is an increasingly recognized immune-mediated, chronic, relapsing, remitting, fibroinflammatory, infiltrative condition. This infiltration has certain criteria. First of all, tumefactive in nature. The inflammatory cells typically results in tumor-like masses. It is not that diffuse. The infiltration is characterized by tumor-like mass in many affected organs, such as salivary, lacrimal glands, the pancreas, and the kidneys. You can see here, this is infiltration in the parotids. It looks like a tumor rather than diffuse inflammatory disease. Submandibular gland affection. Proptosis on the eye, localized or tumor-like infiltration. Mass-like or tumor-like in the lacrimal gland. The thyroid, Riedel's thyroiditis with woody gland, tumor-like picture. So infiltration is characterized by tumefactive nature. This is very characteristic. The second is the infiltrating cells include CD4 cytotoxic T lymphocytes, IgG4 secreting plasma cells, M2 macrophages, activated beta cells, and fibroblasts. The third criteria is classic histologic findings seen on biopsies of the affected organs include lymphoplasmacytic infiltrate, obliterative phlebitis, and storiform fibrosis, with a large proportion of the plasma cells staining positive for IgG4. Another criteria is that multi-organ involvement may occur synchronously together or metasynchronously, one after a few months or years, another organ, and so on, and are usually steroid responsive. We may add here that not only synchronous or metasynchronous, but transient affection may occur. If you look to the first, sentence, we said relapsing, remitting, spontaneous remission may occur in some cases. Like mass, then after a few months, you may make another image of spontaneous. So, summarize the definition. It is a chronic, relapsing, remitting, fibroinflammatory. Infiltration is characterized by active in nature, infiltrating cells, Phlebitis and fibrosis.
ايه دي؟ تشيل دي كده؟ ايه دي تشيل دي ايه؟
Fibrosis.
الزبالة.
دكتور لو
Multi-organ
سمحت مش عارفين نسمع المحاضرة خالص.
synchronously or metasynchronously. Now, the umbrella of the disease start to cover almost every organ in the body. The first recognized was autoimmune pancreatitis, then Mikulic's disease, Kuttner's tumor, Riedl's thyroiditis, hypophysitis in the pituitary, retroperitoneal fibrosis or Lando's disease, interstitial pneumonia, lung, prostatitis, tubulointerstitial nephritis, glomerulonephritis, and so on. The list is still growing. Now we can recognize affection of almost all body systems. IGG4-related pituitary and stalk lesions, IGG4-related hypertrophic pachymeningitis in the meninges, IGG4-related lacrimal and salivary gland lesions, Mikulic's disease and Kuttner's tumor, IGG4-related ophthalmic disease, IGG4-related thyroid disease, before called Riedl's thyroiditis, IGG4-related lung disease, liver disease, sclerosing cholangitis, pancreatitis, IGG4-related kidney disease, retroperitoneal fibrosis, periaortitis and periarthritis, IGG4-related prostate disease. So, what is common between all these organs affection? What is the common link? Is it serum IgG4 level? Initially, it was thought to be a key diagnostic feature of IgG4-related disease, but recent evidence has emphasized the value of elevated serum IgG4 levels, de-emphasized the value of elevated serum IgG4 levels. Several major points should be drawn from contrasting studies. First, elevated serum IgG4 levels by themselves have a low specificity, 60%, and a low positive predictive value, 34%, for the diagnosis of IgG4-related disease. Second, a large proportion of patients with biopsy-proven, clinically validated IgG4-related disease have normal serum IgG4 levels even before beginning of treatment. So it is not a must. It is not IgG4 level. Therefore, reliance on serum IgG4 concentration elevation for diagnosis will certainly lead to substantial underdiagnosis. So remain the question, what is common? Is it cellular infiltration with plasma cells positive for IgG4? Multiple clinical entities can be associated with elevated numbers of IgG4 positive plasma cells in tissue. Yet these conditions lack the characteristic histopathology of IgG4-related disease. We may note now here, this is a long list of patients with suspected IgG4-related disease associated with tissue infiltration by IgG4 positive cells. IgG4 positive infiltration can happen in eosinophilic granulomatosis with polyangiitis, Churg-Strauss disease, granulomatosis with polyangiitis, Wagner, hypocomplementemic urticarial vasculitis, other in hematologic malignancies, Castleman disease, extranodal marginal zone beta cell lymphoma, follicular lymphoma, solid organ neoplasm. In pancreatic cancer, even we may find infiltration with IgG4 positive plasma cells, lung cancer, sarcoma, some infections, pulmonary abscess, Epstein-Barr virus-related lymphadenopathy, aortitis caused by chronic Staphylococcus aureus infection, digestive disease, inflammatory bowel disease, we may find the plasma cell infiltration positive for IgG4, even diverticulitis, other systemic disease like rheumatoid arthritis and histiocytosis. So this is the percent of IgG4 positive plasma cells in some of these diseases. So it is not the common link. The plasma cell positive for IgG4 cannot be the common link. So again to the question, what is common? Now it is recognized that IgG4 related disease is a disease similar to that of sarcoidosis, in that many or all organs systems may be involved, but the diagnosis is unified by distinct histologic findings. It is a characteristic tissue, not a serum level, not a cellular infiltrate, but a tissue as a whole has characteristic feature like sarcoidosis. You may find sarcoid tissue in the lung, sarcoid tissue in the lymph node, sarcoid tissue in the kidney. The same, you may find the characteristic tissue. This characteristic tissue has certain major criteria. Number one, lymphoplasmacytic infiltrate with IgG4 plasma cells. Both beta and T lymphocytes, B and T lymphocytes are present. A monoclonal population rules out IgG4 related disease. T lymphocytes often outnumber B lymphocytes. The second feature is storiform fibrosis, often described as resembling the spokes of a wheel. الحقيقة كلمة storiform from the Latin word for woven mal, الحصيرة. The fibrous tissue looks like the woven mal اللي هي منسوج الفايبرس tissue بالضبط زي الحصيرة. The third feature is obliterative phlebitis, inflammation in the wall of a vein so extensive that the lumen is obstructed. This is distinct from the necrosis seen in vasculitis. So there is no necrosis, it is extensive inflammation that occlude the lumen of the vessel. So we have three major criteria. 2 out of 3 are necessary to put the diagnosis. Other features in the tissue like granuloma, like necrosis, like prominent neutrophilic infiltrate or giant cells usually exclude the diagnosis. They are not seen in IgG4 related disease. So the common link is the unique histopathologic features characterized by lymphoplasmacytic infiltration with positive IgG4 positive plasma cells, storiform fibrosis, obliterative phlebitis. At least 2 should be present. Granuloma is not a feature. Necrosis, giant cells, all are not features. It can affect any organ in the body. So whatever your subspecialty, you should be aware and should keep a high index of suspicion. Now to the pathophysiology of the disease, which is another dilemma. How to categorize this disease? Is it an autoimmune disease? Is it an allergic disease or infective disease? Is IgG4 antibody is a true cause or an epiphenomenon? All of these are on the table. So to clarify, let us go to the basic elements. What are the potential triggers for this autoimmune disease? What are the specific disease pathways that activated during development of this disease? What are the types of cellular infiltrating cells? What are the types of the infiltrating cells? Initiating mechanisms, several reports suggest infectious agents that can trigger chronic infection, whether through molecular mimicry or not, this is not clear. Local autoantigens leading to autoimmunity may be suggested. You cannot say yes, you cannot say no. Allergic component, long-term exposure to occupational compounds has been recognized in certain reports. All these triggering factors in a genetically predisposed person are potential triggers. Okay. what are specific disease pathways? Actually, IgG4 related disease has unique pathways that not typical for autoimmune disease, not typical for allergic disease. For example, the T helper 2 responses are predominantly activated at the affected sites, in contrast to classic autoimmune condition. In classic autoimmune disease, there is predominantly activated T helper 1 activity. But in this disease, it is T helper 2. That's why there is a release of interleukin 5, 4, 10, 13, and TGF beta. Interleukin 5 will lead to stimulation of eosinophils, lead to serum or tissue eosinophilia, which is present in a good sector of IgG4 related disease. Interleukin 13 is responsible for development of beta cells and the plasma cells with IgE production. Serum level of IgE is raised in about 40% of cases of IgG4 related disease, in contrast to typical classic autoimmune disease. So eosinophilia is a feature. High serum IgE level observed approximately in 40% of patients are also mediated by T helper 2 cytokines mimicking allergic disease, but only in 40% and 60% this feature is not there. So I cannot categorize this as allergic disease. Activation of T regulatory cells, in contrast to classic autoimmune conditions in which the function of Treg cells is impaired. This Treg cell will produce interleukin 10, which will stimulate beta cells to maturate into plasma cells and to produce IgG4. That's why IgG4 is high in circulation. Also, it will release TGF beta, transforming growth factor beta, which will stimulate fibroblasts, resulting in fibrosis. So as you can see, this is not a typical autoimmune disease, some features of allergic disease. That's why they put this as immune-mediated disease. It is not fit to the classic features, classic prototypic immune disorders known before. Regarding the cellular response, it has its unique criteria also, characterized by plasma cell infiltration with a high percentage of IgG4 positive plasma cells. T cell infiltration is more abundant than beta cell, in contrast to malignancy and lymphoma. And the infiltration, as we mentioned before, is not diffuse. It talks the tumefactive nature. The cells are the infiltrating cells are grouped together in a tumor-like fashion. Like autoimmune disease, it was found that there is some epithelial damage through autoimmunity. There is some immune-mediated immune complexes, but it is not atypical. It is not the main feature. There is mild immune complex formation. It is unclear whether these organ dysfunction are due to immune complex mediated tissue damage or bystander phenomena. So the same criteria of the disease, some features from autoimmune, some immune complex, and some features from the allergy and tumorification like malignancy. It is nasigun wahda. It is a special entity. Now, let us go for some legal debate about IgG4. We have in our body, as you know, 9 immunoglobulins. Why IgG4 came by a disease by itself? What is wrong in IgG4? What is wrong? Okay. As you all know, we have 9 types of immunoglobulin. All has basic structure. Any antibody structure, 2 heavy chains, 2 lighted chains. Antibodies of IgG class exert 2 major effector functions: activation of complement and opsonization, induction of phagocytosis. These functions are mediated via the constant region, constant fragment, are induced as a result of interaction of the Fab, antigen binding fragment, with the specific antigen. Once the specific antigen attached to the Fab, this will lead to the constant region to induce the function, which is activation of the complement and opsonization and stimulation of the immune cascade. This is typical for any IgG. IgG4 as one of the IgG class has the same structure, but they are released monospecific as all immunoglobulins, but they have a unique feature. Once they are secreted, they engage in a unique process called Fab arm exchange. So they lost their monospecificity, become bispecific, which means that the immunoglobulin 4, G4, released from the plasma cell as any other immunoglobulin with two symmetrical chains. But after release into the circulation, it passes into a unique process called the Fab exchange. Every antibody exchange one of the antigen binding fragment with the other to give us heterogeneous immunoglobulin. This is, you see the blue one specific to certain antigen and the brown is specific to another antigen. Fab arm exchange to yield this heterogeneous immunoglobulin. This heterogeneity and this phenomena is unique for IgG4, and it gives certain criteria to IgG4. It becomes bispecific. And it now will cause block to other immunoglobulins, and it will limit its ability to cause immune complex because it will be very weak combination with the antigen. It will become unable to do good immune antibody complexes. At the same time, it limits the triggering of the immune cascade, limit its ability to evoke downstream signaling and the pro-inflammatory responses. So 3 criteria acquired by the IgG4 after this Fab exchange. It becomes bispecific, lost monospecificity. Every antibody is specific to itself, has only one specific antigen, but IgG4 is bispecific. It has a blocking action to other antibodies. It has a very poor ability to release or trigger the immune cascade. That's why all the 3 criteria confers anti-inflammatory properties. That's why it's unique. I can tell you that this is something in most of our physiologic systems in the body. If you remember the coagulation cascade, we have the coagulation cascade to do its physiologic function when the patient is wounded, to make a thrombus to seal the wound. Once the physiologic process reaches its target, another damping mechanism is the natural anticoagulant mechanism will suppress the coagulation cascade. Otherwise, thrombosis will happen. It is believed now that IgG4 has the same antagonizing effect, anti-inflammatory effect to play with other immunoglobulins. Once these immunoglobulins did their physiologic role, the IgG4 by its anti-inflammatory properties will dampen the other immunoglobulin function. And the IgG4 related disease may be some sort of abnormal prolongation of this physiologic function, exceeding the physiologic limit, like when the antithrombin 3 and protein C and protein S, and if they exceed their physiologic function, a disease will result. I know this, the part of immunology is somewhat tough for you as clinicians, but I hope I was trying to simplify as much as possible. Now, let us go to our clinical aspects. First of all, a message to the clinicians. There is a big diagnostic challenge in IgG4 related disease. Why? Because it closely mimics other well-known diseases, so needs high index of suspicion. Number two, it is rare compared to the disease it mimics, 2 to 3%, for example, of those suspected to have pancreatic cancer proved to be IgG4 autoimmune pancreatitis. Third, there is no single diagnostic test sensitive and specific enough for autoimmune pancreatitis. Rather, all the criteria have to be evaluated together, combined with the clinical response to treatment. Last message, the price of misdiagnosis is heavy. For example, autoimmune pancreatitis mistaken for cancer, major surgery. Cancer mistaken for autoimmune pancreatitis, delay in surgery. So that's why, as clinicians, we should be aware of the disease with high index of suspicion and know how to deal with. Okay, now to the clinical picture. First of all, I will present orally my own experience with this disease, because I think I was lucky with my first contact with this disease. My first contact with this disease, I have two cases came in a short period. First case, it was about 50-something years old lady, around 50, presented by diabetes mellitus in the last 8 months, recently diagnosed, or almost 8 months diagnosed, and came complaining of chronic headache, fever on and off, hemicranial headache, and very high ESR. So it gives me the picture of giant cell arthritis. Clinically, it looks giant cell arthritis. So for giant cell arthritis, we should start full dose steroid to salvage the eye, as you all know. So I prefer to admit the patient because I'll give high dose steroid. She was taking oral anti-diabetic. I expecting I will shift to insulin. So I started the high dose steroid, 60 milligram per day. The patient gave marvelous improvement. Headache improved the second day and fever, but sugar did not rise. That day was the last day of Shaban. The lady insists to go home. Tomorrow is Ramadan. I want to be with family. Okay. So you can go home so long as blood sugar did not rise with steroid. You can go home, and please, after 3 days, you can make fasting.
Please, the sound. Our colleagues, please close the sound if there is any noise.
I asked the lady I discharge her and ask her after 3 days to send me her fasting postprandial blood sugar. After 3 days, I was astonished that they sent me that fasting blood sugar was 70 and postprandial blood sugar was 90 on 60 milligram prednisolone. For me, it was something shocking. So I spent that night really online putting a clinical question. What is the diabetes that improve with the steroid? So I came to a lot of reports describing that diabetes in autoimmune pancreatitis, this is due to insulinitis, beta cell insulinitis, or beta cell inflammation, and it may respond to steroid and recover the beta cell function. This really was my first contact with this disease. I start to read about this. It was something interesting, and start to be aware of the disease. Again, as I said, I was lucky. Few weeks later, before the end of that Ramadan, this is maybe 10 years ago, before the end of that Ramadan, during my round in the clinical ward, I found one young lady admitted as cancer pancreas. She was a miserable lady. When I came to take a history, I found very strange history. They gave me history that this young lady, 3 years back, she had headache and found to have pituitary mass, surgically excised and diagnosed as pituitary granuloma. 1 year later, she has bilateral hydronephrosis and was subjected to OR. In the operating room, when they opened, they found retroperitoneal fibrosis involving the ureters, and this caused back pressure on the kidney, and then they closed and cannot interfere because this is extensive disease. And now, after 2 years of this bilateral hydronephrosis, she presented by pancreatic mass. So at that time, I was recently aware by this disease. When I revised, I found all the criteria, no other explanation with this multi-organ affection, pituitary, retroperitoneal fibrosis, and then now mass in the pancreas. The first possibility to be IGG4 related disease, and we start our work up, but unfortunately, the patient was in a very bad situation. We put the possibility in the last moments. Actually, the patient expired at the same night before we interfere. Another point in that lady, she has excessive lacrimation. And as clinicians, I don't think that we hear in internal medicine, in diseases we face in internal medicine about excessive lacrimation except in this disease. These points are very important in the history. We should find the patient with jaundice, with recent onset diabetes, with MS, and there is excessive lacrimation. You should think in this. Now, this was my first contact. I think these two cases, real cases, can give certain messages. One of the main features of the disease is insidious cause. Acute, fulminant, or highly inflammatory clinical presentations do not occur in IgG4-related disease. In contrast to the rapidly progressive glomerulonephritis seen in ANCA-associated vasculitis, for example, or the catastrophic presentation of antiphospholipid. So, if this catastrophic presentation or rapid acute fulminant presentation, this is unlikely. IgG4-related disease evolves insidiously, does not cause fever, and seldom leads swiftly to organ failure. Here, they put does not cause fever, and I mentioned now, a few minutes back, that I saw one case with giant cell arthritis and fever. So, I found in the literature some exception that in 10% of cases you may find fever. So fever is not a feature. Moreover, many features of disease are detected only incidentally by imaging as retroperitoneal fibrosis or by surgical pathology as IgG4-related aortitis. The slowly evolving nature of IgG4-related disease is one of its characteristic features. The long latency period preceding the clinical detection probably accounts for the fact that about 60% of all patients with IgG4-related disease have some degree of irreversible organ dysfunction owing to damage at the time of diagnosis. The damage brought by the insidious nature of the disease is typified by the complications associated with, for example, autoimmune pancreatitis, which include diabetes and exocrine pancreatic insufficiency. The dramatic weight loss that many patients with autoimmune pancreatitis experience before their diagnosis is often attributable to exocrine pancreatic insufficiency and the consequent inability to digest and absorb nutrients rather than to the constitutional effect of systemic inflammation. Pancreatic failure often occurs before the underlying diagnosis can be established.
بعد إذن دكتور مختار، رجاء اللي فاتح المايك بليز يقفله. شكرا دكتور مختار، تفضل.
الرسالة تكون وصلت للزملاء. So the insidious onset is one of the salient features. Constitutional symptoms, as we mentioned, weight loss of 5 to 15 kilograms is common in patients with IGG4-related disease. By contrast, fever are distinctly unusual and nearly always implicate another disease. But put 10 lines under nearly, not 100%. Usually, fever is not a salient feature. Even patients with multi-organ involvement, لو سمحتوا يا جماعة الفتحة المايك. Even patients with multi-organ involvement and substantial disease burden within an individual organ like lungs can remain asymptomatic for long periods of time. This characteristic means that irreversible organ injury can occur even before the patient is aware of having the disease. A minority of patients, probably fewer than 10%, have weight loss, fever, dramatic elevation of acute phase reactions like ESR and other manifestations of systemic inflammation. So it may be found in 10%. This is constitutional symptom. Now to organ-specific symptoms. These are variable according to the affected organ. As we mentioned before, pancreas, autoimmune pancreatitis, biliary ducts, and you may note here that autoimmune pancreatitis, the presentation is different from typical pancreatitis. The acute severe pain of acute pancreatitis is not a feature because the main brand in autoimmune pancreatitis is on the endocrine pancreas. The main presentation will be recent onset diabetes rather than exocrine. Exocrine may be affected later. Biliary ducts, IGG4 related sclerosing cholangitis, parotid enlargement, lacrimal gland, retroperitoneal fibrosis, IGG4 related aortitis, and so on. The presenting features of IGG4 related disease vary substantially according to the specific specialty evaluating the patient first. If the patient presents to the gastroenterologists, are more likely to encounter patients with jaundice, pruritus, and mild abdominal discomfort. That's what I mentioned a few seconds before. Abdominal pain, severe pain is not a feature, although it is pancreatitis, but pain here is not the main feature. The main feature is endocrinal pancreas and jaundice, followed by or preceded by relatively recent onset diabetes. So a patient presents by diabetes, few weeks, months later, jaundice unexplained, or the reverse jaundice, and a few weeks, months later, diabetes, it should be in mind. The ophthalmologist more likely to see lacrimal gland swelling or other orbital lesions. Nephrologists may see renal dysfunction caused by tubulointerstitial nephritis, or rarely nephrotic regioproteinuria associated with IGG4-related membranous glomerulonephritis, or obstructive uropathy from retroperitoneal fibrosis involving the ureters. As you may notice, all of these has insidious onset. The rheumatologist perhaps most likely to encounter patients with major salivary gland enlargement because this disease feature often raises the spectrum of Sjögren's syndrome. These specialists may also be consulted in the setting of multi-organ disease. The pulmonologist may be faced by pseudotumors, interstitial lung disease, honeycomb lung, mediastinal fibrosis, pleural involvement, and lymph node affection. Complications is another presentation of the disease according to the affected system. For example, meninges, variable neurological complication depending on the site of involvement, cranial nerve pulses from basilar meningitis, for example, posterior pituitary, anterior pituitary failure resulting in deficiencies of thyroid, adrenal, or sex hormones, posterior pituitary failure resulting in diabetes insipidus. I mentioned a few minutes back, the lady presented with pituitary mass. Orbits and cavernous sinus, orbital pseudotumor, proptosis, visual loss, cranial nerve pulses, extraocular muscles, inhibition of full extraocular movement, diplopia and limited field of vision, proptosis, sinus affection, anosmia, loss of taste, destructive bone lesion resembling granulomatosis with polyangiitis or malignancy, lacrimal gland affection, Zika features, salivary, major salivary gland, dry mouth, thyroid glands, woody gland, renal thyroiditis, but Hashimoto's is not part of IgG4 related disease, only renal thyroiditis, pulmonary nodules, pleural thickening and fibrotic pleura, pericardium constrictive pericarditis, fibrosing mediastinitis, thoracic aortic aneurysm or inflammatory abdominal aortic aneurysm, renal affection as we mentioned, pancreas, either endocrine pancreatic failure leading to diabetes, which is more common than exocrine pancreatic affection, biliary tract, chronic hepatobiliary failure, retroperitoneum, chronic pain, hydronephrosis due to involvement of the ureters by the retroperitoneal fibrous tissue, chronic pain due to infiltrating of the mesentery, interference with major vessels like inferior vena cava. All of these may present. So it is a multi-system disease. It should be in differential diagnosis. Now to the epidemiology. Actually, as a newly recognized disease, the prevalence is exactly unknown. Every day there are new reports. As you see, the disease has been typified or crystallized in the last decade, 2011. However, in Japan, the prevalence of the disease has been reported to be approximately 0.28 to 1.08 per 100,000 of population. But this estimate is now outdated and almost certainly constitutes a substantial underestimate. With more awareness of the disease, more cases are recognized. In USA, according to Dr. John Stone from Massachusetts General Hospital, he said here in Massachusetts General Hospital in Boston, averaged 3 to 5 patients evaluated each week as possibly having IgG4 related disease. This is a very high number. And this one group that see this is now following more than 350 patients who have been diagnosed with the disease. It's probably more common than a lot of other conditions than that rheumatologists treat, more common than scleroderma or ANCA-associated vasculitis. Dr. Stone said the new criteria will help further raise awareness. Sex distribution, generally, it has a slight predominance of middle-aged and older males. As we mentioned from the start, this disease is not typical autoimmune disease. Autoimmune diseases are more in females, but this disease more in middle-aged and older men in general, but certain organ affection is more in females. The predilection for older men is certainly true for conditions as type 1 autoimmune pancreatitis, retroperitoneal fibrosis, tuberointerstitial nephritis, and many other organs. However, sex distribution differs somewhat with regard to patients with involvement of the head and the neck. In a prospective study, IgG4 related disease patients, sialadenitis and dacryoadenitis, head and neck affection, and thyroiditis were more common in women. Age distribution, the disease is also increasingly recognized to occur in children. IgG4 related disease described in the pediatric population, general disease characteristics appear to be similar to those observed in adults. However, eye manifestations expressed mainly as orbital mass and to less extent as dacryocystitis are more common. Diagnosis. Now to the diagnosis of IgG4 related disease. So we have discussed the definition and the progress of the disease, how it become well developed and identified. The pathophysiology and the nature of the disease. It is an immune disease. You cannot categorize as allergy or autoimmune, but it is an immune process. We mentioned the clinical picture with the insidious onset and multi-organ affection. Now to the diagnosis. As any disease in medicine, diagnosis depends on history taking, complete and thorough history and physical examination. Then lab serology for IgG4 in serum, more than 135 milligram per deciliter. Eosinophilia may add to diagnosis. Elevated circulating plasma plus is a promising test. Low complement 3 and complement 4 in cases of renal IgG4 related disease. Imaging, as we mentioned, it is characterized by tumor-like lesions, mass-like effect by CT, PET scan, MRI, endoscopic ultrasound, ERCP, all imaging techniques, you may find tumor-like lesion. Then tissue diagnosis, core biopsy or needle biopsy if core biopsy is not possible. Pancreatic FNA for suspected autoimmune pancreatitis, biliary brushing and FNA for cytology. Tissue findings, as we mentioned, IGG4 positive cells to total IgG plasma cells is more than 40%, or IgG4 plasma cells more than 10 per high power field. But this is one criterion only. Other criteria, storiform fibrosis, obliterative phlebitis. Biopsy negative should be negative for malignancy or other specific disease. As we mentioned, you may found in malignancy and in other disease, IgG4 positive plasma cell infiltration. So beside this, you should exclude malignancy from the biopsy. So when you have a patient with clinical suspicion, you will suspect it clinically from the presentation. For example, as we mentioned, any organ presentation, then you found tumefactive lesion in one or more organs, you will go for lab, eosinophils, elevated IgE in 40%, hypergammaglobulinemia, hypocomplementemia, image findings, solitary or multiple nodules or masses. You will go for IgG4 specific studies, which include serum IgG4 level, but you should exclude other causes of high IgG4. We mentioned before the list. Histopathologic studies are cornerstone, looking for lymphocytic infiltration, storiform fibrosis, obliterative phlebitis, eosinophilic infiltration, immune histochemical study for IgG4 positive cells more than 10 per high power field or more than 40% of total plasma cells. Flow cytometry is a promising technique, really. Increased circulating plasma blast is a characteristic, and it may be in the future one of the reliable tests. For example, the EASL, European Association for the Study of Liver Disease, mentioned that diagnosis of IgG4-related disease relies on a number of factors taken in combination, including clinical presentation, IgG4 levels, imaging studies, biopsy evidence, response to treatment, including corticosteroids. And they recommend that clinicians can use one of the following criteria to see if patient may have a diagnosis of IgG4-related disease. There is HISORT criteria. There is Japanese comprehensive diagnostic criteria for systemic disease, and Boston histopathologic criteria. Anyone can be accepted. At least you should know the idea. There is no single test to diagnose. It is diagnosis as any disease in medicine, clinical picture, serology, histopathology, and image and histopathology. For example, this is a comprehensive diagnostic criteria by the Japanese. If you have a suspected case from clinical picture, clinical examination, characteristic diffuse or localized swelling or masses in single or multiple organs. The second criteria, serum IgG4 more than 135. Histopathology, you found the characteristic features we mentioned before, marked lymphocytes and the plasmacyte infiltration, storiform fibrosis, infiltration, IgG4 plasma cells ratio to IgG4 to total IgG more than 40%. If you found one clinical and serum and histopathology, if the three positive, this is definitely IgG4 related disease. If one positive and the three, this means probable disease. If one and the two, this is possible disease. A lot of criteria. But now, after 1 decade of introducing the term IgG4 related disease in the medical field, let us see what happened by the end of this decade. In 2011, International IgG4 related diseases symposium held in Boston put the term IgG4 related disease. Now, after a decade, جرى في النهر مياه كثيرة زي ما بيقول. تمخضت عن 2 landmark events. The 2019 American College of Rheumatology European League Against Rheumatism classification criteria for IGG4 related disease has been issued. In the Western world, they issued these classification criteria. Actually, and in Japan, the 2020 revised comprehensive diagnostic criteria for IGG4 related disease has been issued by the Japanese researchers. Actually, the American European were concerned by research, but the Japanese were concerned by clinical work, and we will see how it comes, because this concern can explain to you the difference between the two events. Now to the 2019 American College of Rheumatology European League Against Rheumatism, they put classification criteria for IGG4 related disease. According to the researchers, the objective of this study was to develop and validate an international set of classification criteria for IGG4 related disease using data from all 4 domains of evidence. They mean the clinical, the serology, the image, and the histopathology. Specificity was a key aim, and this is very important. The criteria are supposed to give greater uniformity to patient selection for studies and ensure that enrolled patients actually have IgG4 related disease. Their goal was, as they said, our goal was criteria that would prevent enrollment of patients without IgG4 related disease. يعني هم كانوا مهتمين جدا بانه ما ياخدوش فولس بوزيتيف، لان هذا الاهتمام ادى الى انهم فقدوا بعض الريال بوزيتيف. يعني هم رفعوا السبيسيفيسيتي لكن السنسيتيفيتي اوف ذا كرايتيريا افكتد، وده نقطه لازم الكلينيشن ياخدها في الحسبان. بالظبط بتفكرنا باللوبس، ال11 كرايتيريا بتوع اللوبس دول اساسا كانوا محطوطين فور ريسيرش، بنستخدمهم في الكلينيكال، لكن بنبقى اوير از كلينيشن ان مش لازم كل عام يكمل 11 كرايتيريا. نفس الشيء بالنسبه للامريكان اند يوروبيان كرايتيريا. الحقيقه هم الكرايتيريا دي خلوها على 3 ستيبس، 3 مراحل عشان تكاتيجورايز البيشنت او تكلاسيفاي البيشنت از IgG4 ريليتد ديزيز. ايه هم ال3 مراحل؟ اول حاجه المرحله الاولى مرحله الاشتباه، انتري كرايتيريا. مين العيان اللي هبدا اخده واقول ده ممكن يبقى IgG4 related disease. The first step in classifying patient with IgG4 related disease is to identify involvement of at least one organ from the list. The panel compiled of 10 organs where involvement typifies the disease. يعني ايه؟ يعني لازم العيان اللي عنده اورجان من ال10 دول افكتد هو اللي هبدا اشتبه فيه. ال10 دول سلام عنده مش هيشتبه فيه. ايه هم ال10؟ البنكرياس، البايل داكتس، اوربتس، لاكريمال جلانس، ميجور ساليفري جلانس، ريتروبريتونيوم، كدني، ايورتا، بيكي مننجيس، and thyroid gland, renal cystitis, but not Hashimoto. Patients who do not have disease involvement in at least one of these organs don't qualify as having IgG4. طبعا involvement هنا المقصود بيه clinical أو radiographic أو pathologic involvement. هنا بلفت نظركم لحاجة. طيب افرض عين جاله الليجن في البروستات، ما هياش من ضمن ال10، مش هيدخل معانا في التقسيم. وده اللي مقصود لما قلنا ان اهتمامهم بالسبيسيفيسيتي جه على حساب السنسيتيفيتي، هيبقى لهم فولس نيجاتيف. لكن هم حاطين دي للريسيرش على اساس يبقوا مطمئنين ان كل الريسيرش هتشمل ريال بوزيتيف كيس. فهم حددوا ال10 اورجانز دول، لكن لو رجعنا في حالات جايه في اذر اورجانز انفولد نوت مش حاطينهم في الكرايتيريا بتاعتهم. يبقى دي اول مرحله انتري كرايتيريا. مين العين اللي هيدخله في التقسيمه؟ اللي عنده افكشن وات ايفر ذا فورم اوف ذا افكشن، كلينيكال، راديوجرافيك او باثولوجيك، في واحد من ال10 اورجانز دول. خلاص دخلنا في الانتري كرايتيريا. المرحله الثانيه الاكسكلوجن كرايتيريا. خد الناس اللي اشتبه فيهم وبعدين هيبدا يستبعد منهم ناس. The next step is to rule out patients who have at least one exclusion criterion from at least 21 exclusions. البانل cited، البانل حددت. الحقيقه هم هنا انا قايل ال 21 اكسكلوجن، في ريفرنس ثانيه تقول لك 32، يعني بيفكوا واحد باثنين، لكن هتلاقوا هم نفس الاكسكلوجن كرايتيريا هي. بيقسموهم الى 4 كاتيجوريز. يقول لك كلينيكال اكسكلوجن، العين لو في فيفر بيعمل له اكسكلوجن which is not right، هيأثر على زي ما قلنا من شويه ان احنا شفنا حالات فيها فيفر، وفي الليتريتشر بيقول انه اراوند 10% ممكن يبقى معاهم فيفر، لكن هنا قال لك لا، الفيفر از نوت ا مين فيتشر، يبقى presence of fever exclude. Unresponsiveness to steroids exclude. Leukopenia وثرومبوسيتوبينيا exclude. peripheral eosinophils ماركت اكتر من 3000 exclude. هي بيبقى فيها ايزينوفيليا بس ما بتبقاش ماركت. طيب سيرولوجيك exclusion، لو عنده بوزيتيف انكا، لو عندي الانتي رو او الانتي لا بوزيتيف، الاكستراكتابل نيوكلير انتي بودي بوزيتيف او كرايوجلوبولينز او اذر ديزيز سبيسيفيك انتي بودي بوزيتيف بيعمل لهم اكسكلوجن. هل ده 100% ريال؟ الكلام ده فيه عليه اعتراض، لان حضراتكم عارفين ان الانتي بوديز دي في نسبه منها بتبقى موجوده في النورمال بوبيوليشن، وبالتالي وجودها لا يعني ان العيان خد تشخيص اخر. ايه اللي يمنع ان تبقى موجوده في عين IgG4 related ديزيز؟ لكن زي ما قلنا في الاول واتفقنا، هم نفسهم قالوا يا جماعه احنا مهتمين بالسبيسيفيسيتي، اي شبهه ان الحاله دي لها سكه ثانيه هنستبعدها. راديولوجي اكسكلوجن، رابيد راديوجرافيك بروجريشن، احنا قلنا ان الديزيز ده انسيديوس اونست، فلو لقوا رابيد راديوجرافيك بروجريشن بيعملوا له اكسكلوجن. لارج بون ابنورماليتي، سبلينوميجالي، concern regarding infection او malignancy او both، لو في اي suspicion ان دي تكون infection او malignancy على طول بيعمل لها exclusion. طبعا هنا مثلا حاطط infection ومالجنسي ايتم واحد، في ريفرنس ثانيه بيحطوهم 2 ايتم، عشان كده الرقم انهم 21 اكسكلوجن كرايتيريا ممكن تلاقوه في مكان ثاني 32. جم منين؟ فك الانفكشن واحده والمالجنسي واحده، وهكذا. اللي مثلا الانكا والبي ار 3 وام بي او انكا فكهم باثنين، انتي رو انتي لايف فكهم باثنين، فلو قريت 32 او واحد
كده بتسال على الجروب بتاع التليجرام، احنا لسه ان شاء الله هنعمله وهنحطه على الجروبات بتاعت الواتساب اللي معظم الناس عليها، وان شاء الله كل الناس تلاقي المحاضره عليه باذن
الله. يبقى ده الراديولوجي اكسكلوجن. يجي باثولوجي اكسكلوجن، برايمرلي جرانيولوماتس انفلاميشن. في مشكله
في الحسبان ان شاء الله. انا منتظر بس حضراتكم تخشوا كده كلكم، ويبقى المفضل العدد اللي نبتدي بيه ان شاء الله.
ما ينفعش كده يا شباب، رجاء قفلوا الصوت يا شباب.
بعد كده نشوف ان شاء الله.
يا جماعه سمعت قفلوا الصوت. يبقى باثولوجي اكسكلوجن، لو لقيت جرانيولوما this is not IGG4، لقيت necrotizing vasculitis, malignant infiltrate, prominent histolytic infiltrate, prominent neutrophilic infiltrate, multicentric Castleman's pathology, prominent necrosis، لقيت inflammation او pseudo tumor pathology، كل ده يعمل لك exclusion. يبقى اول مرحله قلنا في 10 اورجان، لو في واحد منهم affected ابدا اشتبه فيه. تاني حاجه اشوف الاكسكلوجن كرايتيريا، في كلينيكال اكسكلوجن وسيرولوجيك اكسكلوجن راديولوجيك وباثولوجيك، اي كرايتيريا من دول بيستبعدوا. بعد كده if the case meets entry criteria and does not meet any exclusion criteria، هنخش المرحله الثالثه بقى اللي هي مرحله الاعتماد، يابروف بقى ان ده IGG4. The last step is to identify enough individual classification hallmarks in the patient so that collectively they definitively identify IGG4 related disease. هيبدأ يشوف فيتشرز معينة ويعمل لها سكور، ولو السكور ده جمع 20 فأكتر أو 19 فأكتر، فوق 19 يعني 20 فأكتر، بيابروف إن ده IGG4 related disease. يبقى IGG4 related disease inclusion domains and points قدامنا اهو. لو الاي جي جي 4 ليفل نورمال ياخد 0 بوينت، لو فوق النورمال لكن اقل من الدبل الابر ليميت ياخد 3 و7 وهكذا. يبقى هنا يهمني ان ممكن قوي يبقى الاي جي جي 4 نورمال لكن يجمع ال 20 يبقى ده اي جي جي 4 ريليتد ديزيز. ده بيؤكد الكلام اللي قلناه في الاول ان الاي جي جي 4 على عكس ما كنا متوقعين اول ما بدا يتوصف الديزيز انه سبيسيفيك، لا ممكن يتشخص ويبقى الاي جي 4 نورمال في السيرم. نفس الشيء حط سكور للهيستوباثولوجي والاميون ستيننج. ان انفورماتيف بايوبسي تاخد 0، دنس ليمفوبلازموسيتيك انفلتريت 3 و7، دنس ليمفوسيتيك انفلتريت بلس اوبليتاتيف فليبايتس ياخد 6، بلس ستوري فورم فايبروزس ياخد 13 وهكذا. اللاكريمال اند ميجور ساليفري جلاند انلارجمنت هتاخد السكور بتاعها، شيست وثوراسيك اورتال سكور، بانكرياس اند بيلياري ديزيز، كدني، ريتروبروتونيوم. يبقى احنا بنقول انه a case meets the classification criteria for IgG4 related disease if the entry criteria are met, no exclusion criteria are present, with total inclusion points اكتر من 20 فرد. يبقى ببساطه الامريكان كوليدج يوروبيان اسوشيشن كلاسيفيكيشن كرايتيريا هم 3 مراحل. مرحله الاشتباه، مين العيان اللي هحط في الديفرنشال دايجنوزيس بتاعه اي جي جي 4 اللي فيه 1 من ال10 اورجان افكتد. المرحله الثانيه الاكسكلوجن اللي فيه اكسكلوجن كرايتيريا من 21 ل 32. في فيفر يبقى اكسكلودد، الاكسكلوجن طبعا كلينيكال وسيرولوجيك وراديولوجيك وباثولوجي. اكسبتد ومفيش فيه اكسكلوجن احسب له السكور بناء على البوينتس اللي موجوده اللي هي انتري بوينتس. السكور جاب 20 فاكتر، this is IgG4 related disease. طيب ده اللي عملوه الاوروبيين. اخواننا في اليابان عملوا ايه؟ عملوا ال 2020 revised comprehensive diagnostic criteria، راجعوا الدياجنوستيك كرايتيريا اللي حطوها في 2011. الجابانيز team has updated 2011 comprehensive diagnostic criteria and proposed ال 2020 revised comprehensive diagnostic criteria. ايه الكرايتيريا اللي حطوها؟ اهي قالوا ايه؟ 3 items clinical and radiologic features. One or more organs show diffuse or localized swelling or a mass or nodule فيها الكرايتيريا بتاعت الاي جي 4 related disease in single organ involvement lymph node swelling is omitted. يعني ايه؟ يعني لو لقيت one organ affected ده ايتم 1 لكن ما يكونش الاورجان ده lymph node. الليمف نود تتحسب كمالتيبل، يعني لقيت حاجه ومعاها ليمف نود ممكن احسب الليمف نود دي نمره 2 يبقى مالتيبل اورجان افكشن. لو تفتكروا ال10 بتوع اليوروبيان شال الليمف نود خالص ودي احد عيوب التقسيمه بتاعتها. يبقى الكلينيكال والراديولوجيك فيتشر اوكي. الايتم الثاني سيرولوجيك دايجنوز، تلاقي الاي جي جي 4 ليفل اكتر من 135. الايتم الثالث باثولوجيك دايجنوزس، تلاقي 2 من 3 بوزيتيف دنس ليمفوسايت اند بلازما سيل انفلتريشن ويز فايبروزس. الريشيو بتاع الاي جي جي 4 بوزيتيف بلازما سيلز للتوتال اي جي جي بوزيتيف سيلز اكتر من 40%، والنمبر اوف اي جي جي 4 بوزيتيف بلازما سيلز اكتر من 10 بير هاي باور فيلد. ثالث ايتم typical tissue fibrosis particularly storiform fibrosis or obliterative phlebitis. يبقى دول 3 ايتمز، لقيت 2 من ال3 يبقى الباثولوجيك دايجنوزس اكسبتد. الدايجنوزس بيجي ازاي؟ بناء على ال3 ايتمز دول، الكلينيكال والسيرولوجي والباثولوجي. اذا ال3 بوزيتيف يبقى ده ديفينيت دايجنوزس. 1 و3 بوزيتيف بقى بروبابل محتمل، 1 و2 بوزيتيف بقى بوسيبل. طيب حطوا مذكره تفصيليه لهذا الكلام اللي هي 4 نقط. explanatory note number 1 يقول لك انه البروبابل والبوسيبل لو لقيت معاهم كرايتيريا اوف سنجل اورجان افكشن يخليه ديفينيت. يعني ايه؟ احنا بنتكلم النهارده
ولا تشاجر.
ها؟ لو تفتكروا عنوان المحاضره the story as a whole not through a whole. يعني احنا بنتكلم على السيستميك ديزيز، لكن كل سب سبيشاليتي عملوا كرايتيريا للاورجان بتاعها. هتلاقي في كرايتيريا للاوربيتال افكشن، في كرايتيريا للاوتوميون بانكرياتايتس مخصوصه، في كرايتيريا للرينال افكشن. فيقول لك لو لقيت التشخيص كسيستميك ديزيز probable او possible، بس لقيت معاه كرايتيريا اوف سنجل اورجان بوزيتيف ترفع درجه التشخيص الى ديفينيت. دي اول نقطه. ثاني نقطه exclusion diagnosis. بيقول لك مهم انك تعرف انه لما بتكون السامبل صغيره او مسبوعه بهيماتكسول ايوسين، بيبقى انك تفرق الاي جي جي 4 بوزيتيف بلازما سيلز من التوتال بلازما سيلز في بعض الصعوبه، وبالتالي ما تبقاش دوجماتيك قوي في قصه انه 40% بلازما سيل بوزيتيف اي جي جي 4 او الهاي باور فيلد اكتر من 10. يكفيك لو لقيت الاثنين التانيين اللي هم ستوري فورم فايبروز او اوبليتريتيف فاسكولايتس اوبليتريتيف فليبايتس، دول يكفوا لاعتماد الباثولوجي. ده اللي هي الاكسكلوجن دايجنوز. It is important to acquire tissue sample from each involved organ. لا دي سوري يا جماعه اللي انا قلتها دي الاكسبلاناتوري نوت رقم 3. The number of IgG4 positive cells are usually more abundant for resected organs and partially enucleated tissue than in tissue samples obtained by needle biopsy or endoscopic biopsy. Thus, it is important not to be too particular about cell number and provide a precise judgment. يعني خلي نظرتك يعني فيها حكمة، ما تبقاش واقف بالمسطرة في النقطة دي. Story form fibrosis اللي هي بتعرف على انها spindle shaped cells, inflammatory cells and fine collagen fibers forming a flowing arrangement زي الحصيرة زي ما قلنا. أو obliterative phlebitis is defined as fibrous venous obliteration with inflammatory cells. Both are helpful for diagnosis. يعني لو لقيت الاثنين الكاركتيريا التانيين ما تقفش قوي عند قصة ال IgG4 positive cells أكتر من 40%. ده من ناحية الباثولوجي. في explanatory note تانية اللي هي نمرة 2. It is important to acquire tissue samples from each involved organ to distinguish malignant tumors عشان تعمل exclusion malignancy والinfection. ده مهم قوي. رابع explanatory note بتقول ان الستيرويد ترايل is not recommended. However لو العيان خد الستيرويد و not responding للinitial steroid therapy الdiagnosis should be reconsidered. دي الجابانيز كرايتيريا يا جماعه. الحقيقه كان لهم تعليقات انا حسيت ان هي مهم ان احنا نسمعها. معلش انا طولت، احنا خلاص بنفنش المحاضره. Although immune staining of IgG4 and IgG is important for diagnosis of IgG4 related disease, there are no standard for antibodies or staining procedure for IgG4 immune staining. الى الان الاميون ستيننج مالهاش standardization. Therefore, it is often difficult to evaluate IgG4 positive and IgG positive cells due to the background staining, especially في الماينيوت سامبلز لو السامبل صغيره. On the other hand, storiform fibrosis and obliterative phlebitis are reported to be unique and a characteristic feature for IgG4 related disease in addition to lymphoplasmacytic infiltration. Therefore, storiform fibrosis, obliterative phlebitis observed with hematoxylin and eosin staining are helpful for diagnosis of IgG4 related disease, especially in the case with poor staining. هنا كان لهم تعليق على ال 2019 classification criteria بتوع الامريكان يوروبيان. Note for the clinician. The classification criteria were developed only for patients with frequently involved in 10 organs المشهورين. لكن ما جابوش exclude the organs that were not frequently affected زي البروستات زي المننجيس زي السكين. هم عملوا كده عشان يماكسمايز السبيسيفيسيتي، لكن احنا ككلينيشن وي شود نوت ميس. اكسكلوجن كرايتيريا انكلود سبيسيفيك اوتو انتي بوديز زي الانتي دبل ستراند دي ان اي والانتي رو والانتي لا والانكا. thereby patients with some autoantibodies were excluded prior to analysis of IgG4 related disease. مجرد وجود الانتي بوديز دي هم استبعدوا بيه حالات ممكن قوي يطلع فيها حالات اي جي even though they are not accurate autoimmune disease. وبالتالي overall purpose of the classification criteria اللي عملوها الامريكان يوروبيان is to maximize the specificity of classification even if sensitivity is not good. However, physicians in the clinical field you must diagnose exactly and treat all patients in actual clinical practice. بالظبط زي ال 11 كرايتيريا بتاع اللوبس. ما تجمدش دماغك وتقول لي ما كملش ال 11 يبقى مش لوبس. انت العيان بيتوزن as a whole don't prove the diagnosis أو disprove على غياب one criteria. Therefore, it is important to understand the general features of IgG4-related disease, such as organ involvement, clinical symptoms, radiologic abnormalities, laboratory data, and pathological characteristics, and to diagnose patients carefully using either of the criteria. In addition, the revised comprehensive diagnostic criteria should be validated for sensitivity and specificity in future studies. هم بيريكومند ان هم يعملوا فاليديشن للجابانيز كرايتيريا بتاعتهم، يشوفوا تنفع في الريسيرش ولا لا، بحيث تبقى كرايتيريا واحده للاثنين. التريتمنت طبعا احنا كده خلصنا، انا مش هاخد في تفاصيل التريتمنت. التريتمنت زي الاميون ديس اوردرز بيتميز بانه الستيرويد ريسبونسيف، بتبدا ببريدنيزولون من 30 ل 40 مللي جرام من 2 ل 4 اسابيع، وتبدا تتابر 10 مللي جرام every 2 weeks until 20 مللي جرام then 5 مللي جرام every 2 weeks. لو حصل ريلابس وده وارد، هترجع الستيرويد تاني وتضيف معاه الستيرويد سبيرنج زي الازاثيوبرين. في بعض الحالات ممكن تحتاج لو حصل لابس هيبقى المايكوفينولات، الميركابتوبيورين، ميثيلتروكسيت، تاكروليما، ساكلوسفاين. الحقيقه في كلام كتير دلوقتي انه البيتا ليمفوسايتس لها significant رول في الباثولوجي وفي الباثوفيسيولوجي، ولذلك بدأوا يستخدموا السبريسورز اوف بيتا ليمفوسايتس زي الريتوكسيماب، وبيقولوا انه له مارفلس امبروفمنت. لكن المين كورنر ستون هو الستيرويد، وهي الستيرويد ريسبونس بتديه لغايه ما البارامترز بتريجريس، وبتبدا في حوالي 2 ل 4 ويكس. يعني بتتابع لو الاي اس ار عالي بتتابعه الكلينيكال بيكتشر بتاع العيان، وبعد كده بتبدا تعمل جراديوال ويزرول. لو حصل ريلابس بتخش في الستيرويد سبيرنج اورجان. وده شيت عملوه تو فولو الريسبونس، بتحط الكرايتيريا عشان تتابع الريسبونس مع العلاج. To conclude, first identified in the initial years of 21st century as a unified disorder, IgG4 related disease is a multi-organ entity that integrates numerous conditions formerly considered unrelated single organ disease. يعني أجزاء كبيرة من هذا المرض كانت معروفة، بس كنا بنعتبرها كل واحد مرض لحاله، زي الريديوثايرودايتس، زي الميكوليكس سيندروم، زي الكاتنر سيندروم. دلوقتي بقوا one disease. Serum IgG4 levels were initially thought to be a key diagnostic feature, but recent evidence has de-emphasized the value of elevated. The key to diagnosis is immune histochemical investigation of tissue infiltration by IgG4-bearing plasma cells and morphological evidence of lymphoplasmacytic infiltrates, coliform fibrosis, and obliterative phlebitis. Although histological presentation affecting a wide range of organ systems, IgG4-related disease should be clinically suspected in patients with unexplained enlargement or swelling of one or more organs.
لو سمحتوا يا جماعه اقفلوا المايك، اللي عندهم اطفال وعندهم دوشه اقفلوا المايك بليز.
The more clinical laboratory imaging and pathological red flags the patient presents, the greater the likelihood of diagnosis of IgG4-related disease. New research suggests a promising role of flow cytometry analysis in the diagnosis and longitudinal management of IgG4-related disease. بيقولوا انه البلازما بلاست، السيركيوليتنج بلازما بلاست لها ان شاء الله يبقى لها هاي دايجنوستيك ييلد. وبنشكركم واسفين على الاطاله. اي حد عنده سؤال بقى يتفضل.
Thank you Professor Dr. عبد الرحمن مختار for this nice updated and informative lecture about the new disease, IgG4 related disease. And the discussion is open if there is any comment of our colleagues or any question, please.
السلام عليكم دكتور عبد الرحمن. انا محمد سامي، بس عايز اسال حضرتك سؤال يعني.
اهلا يا محمد، ازيك؟
ازي حضرتك دكتور عبد الرحمن؟
وحشنا والله، ده فرصه سعيده، اتفضل.
صح. هو الديوريشن اللي انا ادي فيها تريتمنت ادي لحد قد ايه؟
بص هو الى الان انت
حضرتك قلت الاسترويد وقلت التابرينج بتاع الاسترويد.
ايوه الحقيقه الى الان مش متفق على جايد لاينز معينه حقيقه. الافريج 3 مانث، لكن برضه تعتمد على الريسبونس. يعني انا افتكر انت في عندكم في عياده الاربع كان عندنا مريض كنا بنتابعه قبل ما اجي، كان متحول لنا من مركز جراحه الجهاز الهضمي، هو اتفتح على انه كانسر بانكرياس، وكان السي 19 داش 9 فيه بالمناسبه 12000، وعملوا له بايوبسي اون تيبل لو انفلاماتوري فبعته لنا، فبدانا له الستيرويد وجاب مارفلس ريسبونس، واخر سي 19 داش كان نزل 101. بس كان الجايد لينا الاي اس ار والسي 19 داش والكلينيكال بارامترز، وقعدنا ما بدأناش نعمل ريدكشن الا لما البارامترز نزلت، يعني الاي اس ار نزل وبقيه الكلينيكال واللاب بارامترز بدات تنزل، فبدانا نعمل ريدكشن. ما كانش بالظبط 3 شهور، خد وقت اكتر من 3 شهور، والحقيقه لما جينا نسحب كان بدا يحصل ري انكريفيشن في الماركرز، فدخلنا بالازاتيربرين. الحقيقه ما فيش ديوريشن محدد، لانه زي ما انت شايف it is not a one man show، يعني ده بيأفكت الكدني وبيأفكت البنكرياس وبيأفكت، هل كل جروب بقى وكل تخصص هيبقى له بعد كده البروتوكول في الاورجن بتاعه ميبي، لكن هي بتبقى جايدد بالريسبونس. الافريج 3 مانث.
طيب الريلابس بقى، حضرتك قلت الريلابس هرجع ازود تريتمنت زي الاذاثيوبرين او التكرالو مثلا او السايكلوفوسفامايد او غيره.
نعم.
طيب انا الريلابس ده برجع اعيد الكرايتيريا زي ما كانت بالظبط، يعني انا هشخص بنفس الكرايتيريا اللي انا شخصت بيها الاول واقول ده الريلابس؟
انت مش عليه التشخيص، انت الديزيز عندك زي اي اوتو اميون ديزيز، يعني هو انت عين اللوبس بتشخصه في الاول تعمل له كنترول، او عين الاي بي دي عشان الجسم لما بيحصل له ريلابس انت بتعيد التشخيص من الاول؟
لا طبعا.
لا انت جاست كنترول. وانا فكره الاميون ديس اوردرز انه مفيش فيها كيور، وانما انت كنترول اوف ذا ديزيز، وان كان في كلام ان الاي جي 4 ريليتد ديزيز احيانا يبقى فيه كيور، يعني في ناس بتستغنى عنه، لكن لسه اموره مش واضحه، فهو عمل زيه زي بقيه الاميون ديس اوردرز.
شكرا يا دكتور رحمن.
عفوا يا حمد الله يخليك.
Any other question?
دكتور ممكن اسال سؤال؟
اتفضل يا فندم.
معلش، هو الريتروبيريتونيال فايبروزس اللي هو وانس اوكير ده حصل، هل هي ريفيرسبل مثلا، ولا خلاص الكومبريشن اللي حصل ومش يعني مش هيرجع؟
والله هو الاصل انه الستيرويد ريسبونسيف ممكن يتحسن، ايفن ان في حالات ريبورتد انه في سبونتينيوس ريميشن، يعني في عيان يقول لك تصورت بالايمجنج لقيت في فوكال ليجن في البنكرياس، وتيجي بعد كام شهر تصور ما تلاقيش فوكال ليجن من غير علاج. ده مكتوب في الليتريتشر في سبونتينيوس ريميشن في بعض الحالات، لكن ات از نوت ا ماست، لان زي ما احنا قلنا ان ده انسيديوس ديزيز، فلو انت شخصته ايرلي ممكن يبقى فيه ريجريشن. يعني انا يمكن حكيت مثال بحاله ان انا اديتها ستيرويد على انها جانسيل ارثرايتس، فوجئت ان الدايابيتس ريجريسنج، لكن هل كل الحالات الدايابيتس هيرجريس؟ لا طبعا، بيعتمد ان انت اديته في مرحله الانسولينايتس ولا كان ليت بقى وحصل فايبروزس وحصل بيرمننت دامج. برضه هتعتمد على الستيج.
Any other question please? وكان في سؤال نزل أكتر من مرة، إذا كان حضرتك تسمح ننزل المحاضرة على الجروب لأن الناس كلها
لا
طالبة،
مفيش أي مشكلة،
لأن في ديفكت في السورسز يعني
لا
بالنسبة للموضوع.
معلش هسأل حضرتك على سؤال تاني يا دكتور عبد الرحمن، معلش. السكليروزنج ميزنترايتس دي من ضمن الحاجات اللي كنا بنشوفها ساعات مع حالات اللي اي جي 4 ريليتد سيندروم. السكليروزنج ميزنترايتس برضه بيبقى ريفيرسبل، بترجع تاني زي ما كانت ولا لا؟ لان البيشنت معظمهم بيتحسن كان من حيث الاوتوميون بانكرياتايتس او الهاي بالروبين او كده، بس يجي ما زال الابدومينال بين اللي من الاريتيتنج بالنسبه له بيفضل موجود.
ما هو زي ما بقول لحضرتك احنا في لو انت شفت علينا في مرحله ان حصل بيرمنت دامج خلاص، لكن واحنا اتكلمنا يمكن قلنا في الشيست عاده بتلاقي هاني كومب لانج، لان هو مشكلته انه انسيديوس ويبقى اتمكن منه على ما يتشخص. فاذا كان حصل فايبروزس وبيرمنت دامج اعتقد مش هيطير. ولسه هذه الاسئله يا جماعه ده مرض موصوف من 10 سنين، وزي ما بقول لك انا متصور ان بعد كده هتلاقي بتوع الكدني طلعوا كرايتيريا لهم في العلاج وفي التشخيص وانتوا طبعا في الجاسترونترولوجي والاساتذتنا في الروماتولوجي وكل تخصص هيبدا بعد كده. لكن البرنسبل المبدا العام انه في ستيرويد ريسبونس. هل الريسبونس دي 100% زي اي ديزيز؟ يعني انت لو قسناها باللوبس، اللوبس لما بتيجي تدي الميديكيشن بيكنترول الاكتيفيتي لكن ما بيصلحش الدمج. يعني ايه؟ احنا دايما هو ايه الفرق بين الاكتيفيتي والدمج؟ يقول لك الاكتيفيتي سوري في اللفظ يعني بيت قام فيه حريقه، فانت طفيت الحريقه الاعراض النار، لكن في تلفيات دي الدمج. التلفيات ما فيش حاجه تصلحها. عين جاله ستروك خلاص هيمي باريس، انت ضيعت الاكتيفيتي والفاسكولايتس عملت لها كنترول وريجريسنج، لكن هل رجله وايده هتتصلح تاني؟ انتهينا. ده دمج. ده برضه بيعتمد على الستيج اللي انت شفته فيها. لو هي في مرحله انفلاميشن وسيلولار انفلتريشن اعتقد ممكن يتحسن، انما حصل بقى الفايبروزس والاورجنايزيشن فاعتقد هيبقى بيرمنت دمج موجود.
محتاجين ايرلي ديتكشن.
ما هو الاويرنس ده فكره الاويرنس، الناس تشوفه بدري.
اوكي، في اي سؤال تاني عشان نقفل السيشن يا جماعه؟ خلاص ان شاء الله نكتفي بهذا القدر، وبنشكر مره تانية استاذنا الدكتور عبد الرحمن مختار على هذه المحاضره القيمه، وان شاء الله احنا خدنا منه اذن ان احنا ننزل المحاضره على الجروبز، وان شاء الله التسجيل بيجي لنا من بعد كده بننزله ان شاء الله. شكرا لحضراتكم، والسلام عليكم ورحمه الله وبركاته.